Fine. So anaplastic lymphoma kinase is the gene which is kind of they have implicated in the pathogenesis, and the survival is very poor actually. So that is why these tumors are important to be diagnosed. The earlier you diagnose, maybe the better the outcome. Yet the survival is not so good. Okay. So as I was telling you the region where it is happening, so as you can see the most common is adrenal medulla. Okay. Apart from that, it is of course wherever the sympathetic tract is, it is next to your vertebrae. So this is the paravertebral region. Something which is left out might be in the mediastinum area. Again the posterior, because the sympathetic nervous system or the myelin sheath is going from that zone. And other areas, as I was telling you, could be the head and neck and the brain. Okay. So how do these lesions present as? They can be grossly very small and they can be very big. Okay. So big enough, the diagnosis, the symptoms will be fast, compressive symptoms will be there, the patient will be diagnosed. But usually it is small, so that is why the child is not recognized and it goes late. Recognize something like around 5 years of age when the developmental issues are coming up. At that time you are trying to rule out what is the issue and you get a tumor over there. Okay. If it is big, then it comes to the notice of the clinician and it can be treated very early. Yeah. Fine. So it can be like very small to very big. And it can spontaneously regress as well. It can just stop by itself growing, but usually it doesn't do so. And when you take when the gross comes to us, how does it appear? It could be very, very beautifully encapsulated. It could be infiltrative as well, and it could be like when you do a cut section, it can have hemorrhage and necrosis. Very, very common, because if the tumors are big, they go for hemorrhage and necrosis. Small ones, you will have only greyish white appearance, nothing much. Now histology I'll show you here. So this is how it looks. Yeah, so this is how it looks grossly. If you can see, this is like brown, greyish brown to greyish brown, and it is very beautifully demarcated. It's not infiltrating, but we do get infiltrative tumors as well. And the characteristic of all these blastomas, whatever retinoblastoma, neuroblastoma, nephroblastoma, is small, round, blue colored cells. Okay. So you are getting these small cells which are round in shape. They will be blue. It's because of the stain hematoxylin it looks pink, but we label it as blue, and they barely have cytoplasm. Very minimum cytoplasm. This is the common histology of all the blastic tumors, all the neoplastic lesions of childhood. Okay. So histology you don't have to mug up separately. You just have to remember. Just write the 3 terms. They are small. They are blue color cells. They are round cells with very scant cytoplasm. That's all you get. Some specific features are there to some, I'll tell them. Like in case of neuroblastoma, you get the Schwannanian differentiation. Schwannanian means Schwann cells, the ones which are present in the nervous system. Okay. So these round cells will look somewhere, they will mimic something like the nerve cells. That's all you have to write, because it is neuro, so it is looking something like the Schwann cells. Okay. So that is all the difference about. So very, very easy to remember. 5 marks easily scored. These tumors are very simple. All you have to know is the location. Symptoms also almost they are similar, because they are almost in those areas where they will compress. So you can just write the compressive symptoms. Okay. So like in neuroblastoma, because you have seen it is in adrenal medulla or the paravertebral region. So what will be the symptoms? Something like the adrenal medulla will be producing. What does the adrenal medulla produce? Tell me over there. Adrenal medulla, what does it produce? Yeah. The third and the fourth person from that side. Yeah, you guys were talking, so you only tell. You should be knowing what is adrenal medulla. Maybe that's why you are talking. No idea. Then what does the cortex do? Adrenal cortex. What does it produce? I know I have not taken class, but physiology has been over in first year. Science has been over, so you must be knowing. So if you don't know, then just keep quiet. Fine. So that's what I was telling, the compressive symptoms. So all the when medulla is getting compressed, so all the other hormones which are there in the adrenal cortex, which will be dealing tomorrow, so like the glucocorticoids and mineralocorticoids, they will be produced more because of the compressive symptom. And the kidney, kidney and the ureter, if the tumor is big enough, then the kidney and ureter in that region might be compressed, and so they have urinary incontinence and all those things can be there. If it is in the paravertebral region, then of course you will see a mass. This region is very plain, so there will be a mass. The mother's child will be telling that there is a mass in the paravertebral region. I am able to palpate something. So these are the presenting symptoms. Nobody is going to ask you much about it. All you have to know is the location, The pathogenesis, which is more of genetics, the gross, which is which can be soft, which can be well demarcated, which can be infiltrative, and the histology, which is common for all, that is small blue round cell tumor. Okay, and in this specifically the Schwannanian differentiation or the neural differentiation. If you cannot remember Schwannanian, write the neural differentiation. It will at least give you half marks out of 1. So this is what I was talking about, the Schwannanian differentiation over here. These are the picture is not that clear. They look like nerve cells, and these big cells are nothing but the ganglion cells. These are again nerve cells. If you can remember well enough, if you can't, just the neural differentiation is more than enough. Okay. These are again the ganglion cells. Here the Schwann cells are better. You are seeing these wavy things. These are all the nerve cells, whatever you are seeing. So this is the differentiation. So just see that. 1 second. So this is how the original picture should be, and we can still get this. What it means exactly is blastoma is always an immature form. Okay, like the primitive form, when the child is getting formed, when the baby is an embryo. So these are the immature cells, these round cells, what you are seeing immature. And here they are showing differentiation. They are becoming nerve cells. Fine. So the tumor is bit better. When it is immature, the treatment is more, like it's very difficult, the prognosis is bad. When maturity is there, it's a sign that the prognosis will be better. Okay, so this is what is neuroblastoma showing. Fine. Then the next one is nephroblastoma, Wilms tumor, very common tumor. Like if you are in a clinical practice, then you can say that 1 out of say 1 out of 500 kids, or if you are practicing 1 year as a pediatrician, then you can see at least 2 cases per year of nephroblastoma, very common, not so rare. Nowadays it's even more common. So it's in the kidney, it's nowhere else. And retinoblastoma I am not dealing because it will be dealt in the chapter of eye. Okay, but the physiology is similar, the same small blue round cell tumor, only thing is it is in the eye, and the child will present with symptoms of cataract. So that is retinoblastoma. Details you will study when you are going to eye. So this is nephroblastoma. It's a tumor of the kidney. Okay, and same age, 2 to 5 years of age, can extend up to 10 years, but very uncommon. By 2 to 5 years you will get to see a child. The child will be presenting with distended abdomen and some amount of urinary incontinence, maybe frequency of urine has increased, something like that. And the child may have pain abdomen as well, flank pain. He cannot, child cannot complain of pain. They'll be always crying, and they'll be having these symptoms of frustration, not eating food, and they're not keeping up well, they're not thriving well. So these will be the symptoms by the mother, and when you actually examine, then you might find a palpable mass in the abdomen. If not, then ultrasound and all you do, and you find a mass. Okay. Now what is the presentation of this? Here there is a bit tricky thing that both the kidneys might be involved. Okay, that is bilateral kidney might be involved, and in the same kidney there can be multifocal presence. So that is known as metachronous. In the single kidney there might be 5-6 separate foci of the nephroblastoma. So that is known as metachronous. And when 2 kidneys are involved and they have similar lesions in both the kidney, like say the upper pole is involved in both or the lower pole is involved in both, it is known as synchronous. Syn means together, so both the upper poles, both the lower poles, or maybe the size of the lesion is same. This is 5, this is 5. So this is known as synchronous. And metachronous is in the same kidney, it is at different locations. Okay? So, and it can be bilateral in presentation. So you need to know these syndromes. Just to finish off your answer, that nephroblastoma, if it is there, you should rule out other syndromes. The syndromes are rare but not so uncommon that the patient might not have it. One of them is Wagner, W-A-G-R. Okay, I'm forgetting the entire full form for it, but first one is Wilms tumor, second is A for aniridia, G for growth retardation, and R for I think renal dysfunction or retinoblastoma. I'm forgetting that. You'll be reading this when you're going to your 3rd year. So that is Wagner syndrome. W is Wilms, A for aniridia, G growth retardation, and R you can just Google or refer your textbooks and see. The second syndrome is Danish-Dras. Okay, and the third one is Beckwith-Wiedemann. These are all associated with nephroblastoma. It's given in your textbook. You need not have to write. It will be there. Okay. Now what, as I was telling you, clinical features we have seen. Yeah, it can also have hematuria. It can involve that. And there is one more thing, that this tumor can metastasize to the lungs. So you can get some symptoms of the, lung symptoms like breathing problem or continuous infections. That is how pediatric patients present mostly. Adults are not so much prone to infections, but kids are. So when you do an ultrasound or maybe you do some biopsy, then you are getting directly you are diagnosing with the pulmonary nest. You have not gone to the kidney and first you are getting at the lungs. Okay, so that can be one. And again coming down to the gross is again similar. It can be anything. It can be well demarcated. It can be infiltrative. It can be homogeneous. Homogeneous means the entire gross is looking same, like the entire tumor is same everywhere, wherever you go. Variegated means the tumor has different appearance at different places. Somewhere it is solid, somewhere it is grayish white, grayish brown, hemorrhagic necrosis. This is variegated appearance. And homogeneous means the entire tumor is looking same. So this is more of an homogeneous tumor, and it is well circumscribed usually, but can be infiltrative, not like that, and sometimes can be solid cystic. Okay. And histologically we will go. Okay, so this is how the tumor is, and this is the part of the resected tumor. So just leave that. This is the big tumor, and there is a small tumor here, as you can see. And you can see that everywhere they are uniform. They are almost homogeneous, white, grayish white in color. Nothing much like hemorrhage and necrosis, which we had talked about in neuroblastoma. Okay. Now when you are seeing here, again these are small round blue cell tumor. That is the common sentence. Apart from that, they are showing some amount of differentiation. So there are three differentiation in them. First, they are trying to become epithelial cells. So you are seeing an epithelial differentiation. Okay. Second, the core blastema cells, the blastocytes, the blastoma jo hai, that immature form, that is being maintained. So that one is the blastomal cells. If you can remember for blastoma, it is the blastomal cells. And the third, again they are trying to become something like neural or fibroblastic origin, so the spindle cells. So these are the three things you get to see, but you can see eventually all of them are looking somewhat similar. Though these are all deep round blue cells, these are trying to form some kind of rosettes, and these are the spindle cells, somewhat looking the same. So they're all similar, only thing is they're trying to mature themselves into something. So Wilms tumor, nephroblastoma, blastic cells or blastema cells, epithelial nephro is an epithelial thing, kidney is an epithelial organ, so epithelial cells, and whatever the rest is covered by, whatever the ducts and tubules, they are supported by the mesenchymal cells or the spindle cells. If you can remember like that, if you know the histology, you can remember like that. Okay, so the opening statement should be small round blue cell tumor and consisting of epithelial, blastemal and spindle cells. Okay, so these are the two tumors, neuro and nephro. Neuro all over the wherever the myelin sheet is. This I am telling you to remember, don't write it over there, just for your reference, that myelin sheet starts from the brain and up to the coccyx region. So the tumor can happen anywhere, but the most common is the adrenal, medulla and paravertebral, wherever the sympathetic chain is. Okay, and rest of the things are same. Nephro, known for the nephrology, it's in the kidney. It's Wilms tumor. Okay, these are the two. What happened? Okay, so these are the two tumors, and retinoblastoma will be one more question which we will be reading in eye. That will be one of the last lessons which we will be finishing. Okay, settle down. So the last topic for today, it's the storage disorder. This one, if you want, you can note down here, or in your textbook you have it in the chapters of, if I am not wrong, genetics I guess or something. Okay, it's not in the chapter of diseases and infancy. Fine, shh, no talking. No talking. Okay, now what are these storage disorders? Okay, so so basically this is a bit complicated and they are very big. Okay, I don't know if in biochemistry you have read or not, if you have paid attention that time. So overall, if you try to understand the concept, that is more than enough. You can at least fill in something, and remembering each and every, because there are like 76 different glycogen storage disorders just now. They are going on and on and on. They are adding to the list. Okay. Same way, lysosome storage disorder, lot of names are there. So you cannot remember each and every one of them. It's not possible. So overall, if you have an idea, it is easy. So what is a storage disorder? See, in your body there are glycoproteins, there are lipids, there are proteins alone. There are so many things, and everything is stored somewhere or the else. Okay. To store that or to create that thing, there is a substrate, there is an end product, and there is an enzyme. That is how it is. I hope everybody is clear, right? There is a substrate, there is an end product, and there is an enzyme which is creating the end product from the substrate. So when the enzyme is not there, or it is dysfunctional, or it is produced less, or there is deficiency or whatever, all these different reasons, the substrate is getting accumulated. Something which we read in phenylketonuria and galactosemia, something similar. Okay. So either the substrate is getting stored unnecessarily, which is not required, or the enzyme is very active and it is producing lot of these end products, and those end products are too much for the body to utilize and they are getting stored. Okay, so now there are two basic storage disorders. One is the lysosome. Why lysosome is so important? Any idea what is the function of lysosome? Over there, lysosome function. उठ जाओ उठो भाई. हाँ आप ही बताओ, लाइसोसोम का फंक्शन बताओ. आपके दोस्त को भी पूछो, वो भी बताएगा. उठो. लाइसोसोम का फंक्शन तो पता है, कोई टफ क्वेश्चन थोड़ी है. आप लोग बताओ. आप सेकेंड रो में ग्रीन, आई डोंट नो योर नेम, आई एम सॉरी, गेट अप. Lysosome function, basic organelle from 7th standard science, I guess. Endoplasmic reticulum function, all of them, all the ERs produce protein synthesis. Okay, good. This one everybody knows. So what is the lysosome then? Okay, wait. Just, you are not supposed to sit. If you sit, you will again start talking. हाँ, लाइसोसोम क्या है? 1%. अभी तो कोरस में दे रहे थे. लाइसोसोम क्या है, क्या करता है? Sorry, I can't hear them. Intracellular digestion by lysozymes. Any idea which group of enzymes they are? Hydrolysis. Okay, fine. Sit. खड़े होके भी बात करना है. मतलब जिंदगी में और कुछ है नहीं, तो वो बोल रहे तो क्या हुआ, तुम्हें सुनना जरूरी है. ठीक है, फाइन. पे अटेंशन हियर फॉर सम टाइम. ओके, क्वाइट. See, you have to talk, you sleep. Early morning, who wants to talk so much? What, Sunday was missing or something? You want to update each other? Hey man. ठीक है. तो लाइसोसोम जो है, it's a basic, like whatever is produced by the endoplasmic reticulum, the rough endoplasmic reticulum is taken up, is packed by the Golgi bodies. Okay, and it is taken down for storage. Golgi bodies is the one which stores. So whenever you have to produce that thing and you have to take it out and you have to utilize it in the body, wherever it is, so inside the cell, lysosomes will come into action and they will destroy the bubble of the Golgi body and they can be done. Otherwise, if it is not required, then the lysosomes fuse with the Golgi body and they destroy whatever is inside that. That is one function. Apart from that, when the cell wants to die, the mitochondria is getting older, be it mitophagy, be it phagocytosis, be it autophagy, anything, lysosomes are the one which go and attach and they produce this hydrolysis and they kill everything. So basically what is lysosome? It's a lysozyme. It's a clearing enzyme. Whatever is extra is being cleared out by lysosome. And this is a day-to-day process. Okay, it's happening daily in our body. When it is not happening, then definitely things are getting stored which is not required. So this is what is lysosome storage disorder, where lysosome is dysfunctional because of numerous reasons, maybe from genetics, maybe from infections or anything, that we'll just go about them. So because of that, things are getting accumulated in the body which is not required. Okay, fine. So okay, intracellular digestion was written here, that's why you guys were screaming. Okay, I didn't see it. Okay, so they create this acidic enzyme, acidic environment, that is because of the hydrolysis. And fine, so when they are deficient, what is happening, we'll just go about it. As I was telling you, whatever the substrate is that will not be cleared, whatever the substrate is that will not get cleared because lysosome is unable to digest it. So that is what is happening. So instead of, it is not like always a complete deficiency, because nobody can survive with that much. As I've always remember, this is a rule of thumb, anything cannot be completely deficient in your body. If it is zero, like zero is never a thing. If it is zero, then the child will die, like stillbirth, or even in adulthood we will die.